Hi guys, welcome to today's session. Today we are here to talk to you about the clinical based scenarios in surgery. Let me just see if it all everything is fine. If you can hear me properly, just give me a thumbs up. I hope I'm audible to you guys. Hi guys. I hope I'm audible and visible to you. Can I just have a thumbs up from you guys? Okay, great. So now let's begin. Can I just have a thumbs up from you guys if I'm audible and visible to you properly? Right. So okay, guys. Hi. Welcome to today's session. Today, we are going to talk about the clinical based scenarios in surgery. Before talking about this, I'll just introduce you to my rituals. So, basically, I take live classes also on the Unacademy platform. There, I have just started with kind of a TND sessions. So, I have started with the TND sessions, and which I basically take at 11 a.m. Okay, so every day at 11 a.m., I'm going to have a TND session on the Unacademy platform, so you can basically come and attend it every day starting from today. So today I just took like the episode 1, and it is going to continue till episode 20. So every day starting today, I'm going to have a kind of a T&D session on the Unacademy platform, so you can basically come and have a look at over there. Okay, that's the first thing. At the same time, on the YouTube, I usually come live at 12 p.m., like this particular session. So yeah, you can basically come and follow me over here as well. Without wasting any further time, let us begin with the first question. So the first question, what does it say? It basically says that there is a teenage boy who basically fell from a bicycle and he was run over by a truck. Okay, so patient had suffered from a road traffic accident. So there is a road traffic accident which is happening in this particular patient. Okay, now on arriving to the emergency room, the patient was awake and alert and appears to kind of have frightened with no distress. So he is more or less stable. Okay, so what do we have till now? We have a road traffic accident patient who is more or less stable. If at all you do a chest radiogram, now here there is a click. So if at all you perform a chest radiography in this particular patient, this is suggestive of an air fluid level in the left lower lung field, and the nasogastric tube coils upwards in the left chest. Okay, so which of the following, what do you think, is the next best step in the management of this particular patient? Will you go in for a placement of a left-sided chest tube? Will you go in for a thoracotomy? Will you go in for a laparotomy, esophagostomy, or a diagnostic peritoneal lavage? What do you think, guys? What will you go for? So, okay, guys, I'm waiting for your answers. What do you think? What will you go for? So here, I'll just summarize everything for you guys. So what do we have? We have a patient who is coming to you after a road traffic accident. The patient is more or less stable. Okay, so the patient is more or less stable. And when you performed an X-ray in this particular patient, what did you find? You found that there was a air fluid level. Okay, so first thing which you noticed, that there was an air fluid level, and the another thing was the nasogastric tube. It had basically coiled in chest. Okay, so the nasogastric tube had basically kind of coiled in chest. So I'm getting the responses. Some of you guys are saying that laparotomy, one of you guys is saying thoracotomy, another is saying that diagnostic peritoneal lavage. Answer to this particular question is in fact the laparotomy, guys. Okay, so what is the diagnosis? Can you please help me, guys? What is the diagnosis of this particular patient? So diagnosis in this particular patient is diaphragmatic. It is a diaphragmatic rupture. Okay, do you get this point, guys? So here the patient is asymptomatic, but the patient is having a diaphragmatic rupture. Now, okay, do you get this point? I hope you get this point, right? So around 4% of the patients with a blunt road traffic accident, they might come to you with a diaphragmatic rupture. Most of these patients are asymptomatic when they basically present to you. And the buzzword which you are basically getting is coiling of the nasogastric tube in the chest. Okay, coiling of the nasogastric tube in the chest. So just this particular finding gives you the diagnosis. It gives you the diagnosis, guys. Okay. So if at all there's a diaphragmatic rupture, what you need to go for? You need to go in for a laparotomy. You need to take the kind of intestines and everything down into the abdomen and close the defect. Why? because if you do not do this, or if at all you delay in this particular process, what is going to happen? There is going to be an ischemic changes in the bowel, which is not going to be a good thing. Okay, so patients like the bowel might undergo an ischemic changes, and there might be perforation. That is why you have to go in for a laparotomy, and you have to bring the intestinal segments down, and you have to close that kind of diaphragm. Now, in this particular scenario, the diagnosis was very, very clear, right? Because the X-ray was showing that the nasogastric tube is basically coiling in the chest wall. That is why it was very, very clear. If at all the diagnosis is not clear, if at all the patient is just asymptomatic, on the X-ray nothing is seen. So, can you please tell me, guys, what is an investigation of choice to diagnose diaphragmatic injury? What is an investigation of choice to diagnosis in the diaphragmatic injury? Can you please help me with this, guys? So I'll give you the options. Like, what do you think? What is the answer? Is it an MRI? Is it a CT? What do you think? What exactly is the investigation of choice to diagnose a diaphragmatic rupture? Now, right. So right. So diagnosis. This is basically based by like diagnosis. This is basically done by the diagnostic laparoscopy, guys. Laparoscopy. Now, you might feel that the patient is having, let's do an MRI, and because this diaphragm is a soft tissue, we might be able to pick it up on the MRI. Please do not mark it, guys. That is the most common wrong answer which the people mark. MRI, that is not a correct answer. The kind of investigation of choice in this particular patient is a diagnostic laparoscopy. Please understand this, right? So Shiv Shankar is basically asking us, okay, what do I mean by the why do you have this air fluid level? Now, air fluid level is basically present because the part of the intestine is basically going up, right? So the part of the stomach is basically going up into the thoracic cavity. Because this part of the stomach is going up, in the stomach you have the air, you have a fluid, and that is why you are getting the air fluid level. It is not because of the hemopneumothorax. Okay, that is just given to kind of confuse you. Do you get my point? So it is just given to confuse you. The buzzword is basically the nasogastric tube. It is coiling in the left chest. Everybody's clear with this? The diagnosis is a diaphragmatic rupture, and that is what you get in this, right? Let's move on to the next question. Next question which we have, guys, there is a 38-year-old kind of a male who is a chronic smoker and has a history of an uncontrolled hypertension. The patient comes to the emergency room with a sudden onset of a tearing chest pain which radiates to the back. Now, this is a kind of a buzzword, guys. Okay, so kind of sudden onset of a tearing chest pain which is basically radiating to the back, right? Now, there is an unequal pulse in the upper extremities, and the chest X ray basically shows a widened mediastinum. What is the most likely diagnosis in this particular patient? Is this particular patient suffering from a dissecting aortic aneurysm, myocardial infarction, pulmonary embolism, or an acute pancreatitis? Can you please help me with this, guys? What do you think? What is the answer? Right. So, in the previous question, when I asked you that what is the investigation of choice, I see many of you guys are answering it as a CT and the USG. Please understand, CT, USG, MRI, that is not useful for the diagnosis of a diaphragmatic rupture. What we basically use is then diagnostic laparoscopy. Please, please, please put it in your mind. It is very, very important. Coming back to this particular question, guys, what do you think is the answer? So, everybody's right. They are basically, each one of you is saying that it is a dissecting aortic aneurysm, and that is absolutely, absolutely correct. Okay, what is this person suffering from? The person is suffering from a dissecting aortic aneurysm. Now, let us break this. But you have a patient who is a chronic smoker and who is an uncontrolled hypertensive. So, if I just ask you, what is the most common predisposing factor? Okay, what is the most common predisposing factor for kind of a dissecting aneurysm? Dissecting aneurysm. What is the most common predisposing factor? The answer is hypertension, guys. Okay, uncontrolled hypertension. So this particular person is having this. Now, if at all the patient develops this dissecting aneurysm, the patient is going to have this tearing, like the severe onset chest pain, which is radiating to the interscapular region. That is a buzzword, okay? So sudden onset severe chest pain, which is radiating to the interscapular region, that is the buzzword in this particular question. Another important thing is on the X-ray. So if I just ask you, what is the X-ray finding in these particular patients? If at all there is a dissecting aneurysm, on the X-ray, you basically get a widened mediastinum. Okay, so please remember, what do you get on the X-ray? You get a widened mediastinum. This is basically a finding on the X-ray which we get in the dissecting aortic aneurysm. Now, what you're basically seeing over here, this is a CT scan of the patient. So I hope you're able to appreciate this black colored line, this black colored line over here, this black colored line over here. This is basically a undulating membrane. Now, dissecting aneurysm, what exactly is happening in the dissecting aneurysm? The blood is entering into the endothelium, it is going into the muscle layer, right? So this undulating membrane, this black colored membrane, this all needs to be white because this is a contrast enhanced CT scan. It all needs to be white. But here, the presence of this kind of black colored membrane in between, this indicates that the patient is basically suffering from a dissecting aortic aneurysm. So this is a CT scan, which is very, very important. You have to remember it, okay? I hope you get this. Right. Now, okay. Though that's all about the dissecting aortic aneurysm. So what you're basically trying to say, Teja, that rupture of the ligament, that is usually for the aortic rupture. Here, the aortic rupture did not happen. Here, just the dissecting aortic aneurysm is happening. Okay. I hope you get this. This you need to remember. What is the X-ray finding of this? So there is a widened mediastinum. What you will get on the X-ray, you will get a widened mediastinum. Okay. Understood it? Right. So can we do E-fast? No, we cannot do E-fast in this. Okay. Okay. So how will you diagnose this? What is okay? So because the teacher is asking us, if I just ask you, how will you diagnose this particular patient? So the diagnosis, this is basically depends on the whether the patient is stable or not. Okay. So whether the patient is stable or unstable. If at all the patient is unstable, okay, if at all the patient is unstable, then you will have to go in for a trans esophageal echocardiography. We'll have to go in for a transesophageal echocardiography. But if at all the patient is stable, okay, if at all the patient is stable, then we can basically go in for a CECT. Please understand. Investigation of choice in the stable individual, that is a kind of CCT. If at all the patient is unstable, you will have to go in for a transesophageal echocardiography. Do you get this point? Right. Now, right. Shiv Shankar is asking why there is a difference of the pulses. Okay, so please understand. Let's say this is the aorta, right? So let's say this is the aorta. So what is happening over here? Let's say the dissecting aortic aneurysm started from this particular point. Okay, so till then the vessel, like the right-sided vessels, were already given off, like the brachiocephalic trunk that had already been given off, and then you have the right side carotid and the right side subclavian. So what you're going to have, like if at all there is a dissecting aneurysm which is happening from this particular point, the pressure on the left side of the arm, which will be lesser as compared to that of the right side of the arm. At the same time, the pulses will also be different. Okay, so I hope you get this. Do you get this? Shiv Shankar, do you get this? Right. So Kapil, what we need to go in, we have to go in for a, it depends. It depends whether it is a Stanford A or Stanford B. Usually we go in for a repair. Like you have to go in and you have to go in for a coiling of this, right? You have to go in for a coiling. But yeah, I mean, if at all there is a Stanford type B, which is involving just the kind of descending aorta, you can go for a medical management for the time being. But if at all there is a Stanford type A, we have to definitely go in for a surgical intervention. Do you get this? Right. So nobody's going to ask you the nitty gritty of the treatment part, but yes, they will definitely ask you what is an investigation of choice. So just pay attention over this. Okay. Got that, Apple? It is basically depending on the Stanford classification. Stanford type B, we can kind of go in for a medical management to begin with, but yeah, Stanford A, immediate surgery, right? Okay. Let's move on to the next question, guys. So there is a patient who has been brought to the emergency department after a blunt trauma of the chest. Okay. On examination, what you're basically finding that there is a shortness of the breath. Okay. So the patient is in the respiratory distress. Okay. So let us kind of make you as a doctor. So you are a doctor in the emergency room. So you are basically doc in the emergency room. Now there is a patient who is basically lying down over there, and this particular patient is in respiratory distress. Okay, so this particular patient is in the respiratory distress. Now, what else? When you went toward this particular patient, the trachea of this particular patient was deviated toward the left side. Okay, so what else? The trachea was deviated towards the left side. So where was trachea? It was deviated towards the left side. What else? You took a stethoscope because you're a doctor. So you take a stethoscope, you try to auscultate this particular patient. On auscultation, what did you find? That the breath sounds are absent. So on the right lower chest. So if at all you kind of auscultate this particular patient, the breath sound is absent on right side. Okay, so there is a breath sound which is basically absent on the right side. Okay, Then what happened? You also did a percussion, like you were a complete doctor. So you also do a percussion. On doing a percussion, you get basically a dull note. Okay, what did you get? You get a dull note on doing a percussion. So the last point was when you did a percussion, you get a dull note. So now can you please tell me what is the diagnosis of this particular patient? So what you have done, you have gone to a patient who was in the respiratory distress. When you examined the patient, the trachea had deviated towards the left. On auscultation, there was an absence of the breath sounds on the right side, and then on percussion, you got a dull note. What do you think, guys? What is the diagnosis of this particular patient? You guys are saying that it is dull note, so it is a hemothorax. Okay, right. So most of your guys are right. Roshni is basically saying it's a no Roshni. It is not a tension pneumothorax. The answer is hemothorax. Why it is a hemothorax? You are absolutely correct because you are having a dull note. Most probable diagnosis of this particular patient is a hemothorax. Now, understand one thing, understand one point, guys. Okay. Now, if at all I wouldn't have given this dull note, if at all instead of dull note, it would have contained a resonant note. Okay. If at all it would have contained a resonant note, then what would have been the diagnosis, guys? If at all it would have been a resonant note, then it would have been a pneumothorax. Okay. If at all this would have been a resonant note, then the answer would have been a pneumothorax. Rest, all the things would have been exactly the same. The patient would have been in the respiratory distress, the trachea would have been on the left side, there would have been no breath sounds on the right side, but instead of the dull note, you would have got a resonant note. Do you get this point, guys? So this is a contrast. If at all you get a dull note, the answer is hemothorax. And if at all you get a kind of resonant note, the answer becomes a pneumothorax. Everybody got this, right? Okay. This is an important thing which you need to understand. Now, let us move on and let's talk about the next question. So, what do we have? There is a kind of a 41-year-old male who is basically complaining of regurgitation of the saliva and undigested food. So, there is an undigested food which is regurgitating, right? On the esophagogram, this basically reveals a dilated esophagus and the bird's beak deformity. Manometry, it basically shows a hypotensive lower esophageal sphincter with a failure of relaxation with deglutination. Which of the following is the safest and the most effective treatment for this condition? So it is a giveaway question, guys. Okay, it is a giveaway question. What is the diagnosis? So here there is a kind of a esophagus which is having a bird's beak appearance, and there is a hypotensive lower esophageal sphincter. So all these things are giveaway. The diagnosis is an achalasia cardia. So what this particular question is trying to ask you, what is the safest and the most effective treatment for this particular condition? Is it a medical treatment with a kind of nitroglycerin nitrates or the calcium channel blockers, repeated boogie dilations, injection of a botulinum toxin, or dilation with the kind of dilation, or it is a surgical esophagectomy? So what do you think, guys? What is the kind of esophagomyotomy? What is the safest and the best treatment for this particular condition? What do you think, guys? What is the answer? If at all you say that the answer to this particular question is a surgical esophagomyotomy, then it is the correct answer, guys. What is the answer? Answer is E. That is a surgical esophagomyotomy. That is the correct answer. Do you get this? Right. No, 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 no. Shivshankar, it is not C. No. Botulinum toxin, no. The answer is surgical esophagomyotomy. Okay. So now let me just walk you through the treatment options for the achalasia cardia. So in the achalasia cardia, what are the treatment options do we have, guys? In the achalasia, what are the, okay, guys, the answer is E. Answer is E. Okay, answer is E. Surgical esophagomyotomy. Do you get this? Answer is E. Now, in the achalasia cardia, what are the different treatment options which we have? We have basically a drug treatment. So we can basically go in for a medical treatment with the help of this nitroglycerin and the calcium channel blockers and the nitrate. We can go in for that. So yes, there is nitrates and the calcium channel blockers. We can go in for that, but they are not very much effective. So we usually do not prefer to go with that. Okay. So yes, medical treatment, that is one of the options. What is the another option which we have? We can go in for a endoscopic management. Endoscopic management. In the endoscopy, what we can basically go for, we can either go for a botulinum toxin. Botulinum toxin. So what is this botulinum toxin, guys? If at all you inject this botulinum toxin, what is it going to do? It is going to dilate the lower esophageal sphincter. Because of this dilation of the lower esophageal sphincter, whatever the food you eat, it will easily enter into the stomach. So what is this botulinum toxin? We use type A. Okay, we usually use a botulinum toxin type A. Which type of a botulinum toxin is used? We usually use type A. Another thing which we can do on endoscopy is basically dilation. So we can basically put a balloon dilation or something and we can go in for that. What is the drawback of these endoscopic therapies? First of all, they are not that effective. It is kind of effective only in 70% of the patients. Only in 70% of these particular patients, these therapies are effective. And at the same time, we need to repeat it. Okay. So after 6 months, we have to repeat this. That is why we are not that much fond of an endoscopic treatment. We usually do not prefer to go in for this endoscopic therapy. Okay. Then what is another option which we have? We can actually go in for a surgical management, and this is the best and the safest option which we have. That is what is called as a Heller's cardiomyotomy. What is this? This is Heller's cardiomyotomy. Please understand, the efficacy of this particular procedure is close to 90 to 95%. Please understand. With the dilation, it is a risky procedure. That is fine because the kind of esophagus can rupture, it can undergo stenosis and everything. It is a risky procedure, but at the same time, even the efficacy is around 70%. But in the Heller's cardiomyotomy, the efficacy is 90 to 95%. It is a simple operation, usually not with a lot of complications. Do you get this point? So this is something which you need to understand, guys. Okay. Right, right. Okay, got this, guys? Everybody understood this? Right. So now let us move on and let us talk about the last question of the day. So here, during an appendectomy, okay, you found that for the acute appendicitis, you basically kind of removed that appendix, and there was a 4 centimeter mass was found in the mid portion of the appendix. Okay, so in the mid portion of the appendix, you found a 4 centimeter mass. Now the frozen section basically revealed in this particular section to be a carcinoid tumor. So you took a frozen section from this, biopsy from this, you send it, and it reveals a carcinoid tumor. So what do we have at this moment? We had planned a laparoscopic cholecystectomy for appendicitis. We found that there was a 4 centimeter mass in the mid of the appendix. We took a biopsy, sent it for the frozen section. It came back as a carcinoid tumor. Now, which of the following is the most appropriate management for this particular patient? What do you think, guys? What is the most appropriate management for this particular patient? Will you go in for an appendectomy followed by the colonoscopy, appendectomy followed by the PET scan, right hemicolectomy, or a total proctocolectomy? So what will you go in for, guys? What do you think? What is the answer? Answer to this particular question is in fact a right hemicolectomy. So it is a pretty simple question. What you need to understand, the management protocol of a carcinoid of an appendix. So let us kind of walk you through it. Okay, so management of carcinoid appendix. How do you manage it, guys? You basically divide these appendix tumors into less than 1 centimeter lesion, more than 2 centimeter lesion. Okay, you first divide it into less than 1 centimeter, more than 2 centimeter, and then you have a mid range that is between 1 to 2 centimeters. Okay, so you basically divide it into these three. If at all the lesion is less than 1 centimeter, what you basically go for, you just go in for an appendectomy. Okay, what you just need to go in for an appendectomy. If at all it is more than 2 centimeters, no doubt at all you have to go in for a right hemicolectomy. Do you get this? Here you have to go in for a right hemicolectomy. Now, if at all the lesion is between 1 to 2 centimeters, you have to see if at all this particular tumor is at the tip, and if at all the mesoappendix is not involved. Okay, if at all this particular tumor is at the tip and the mesoappendix is not involved, you have to go in for an appendectomy. Straight away, go in for an appendectomy. But if at all this particular tumor is at the base of the appendix and the mesoappendix is involved, okay, if at all it is at the base of the appendix and if at all the mesoappendix is involved, then you will have to go in for a right hemicolectomy. So I hope you got this. This is a simple management of a carcinoid of appendix. Please do go through this. Okay. No. Less than 1%, we have to go in for an appendectomy. Carcinoid tumor, it is a tumor, so you have to go in for an appendectomy. It is not observation, not at all. You have to just go in for a simple appendectomy, okay? A simple appendectomy. You just have to go in for a simple appendectomy. Everybody got this, guys? So this is how you'll manage a patient of a carcinoid of the appendix. Everybody got this, right? Okay, guys. Right. So, guys, this is all from my side for this particular thing. If you wish, I'll just kind of revise the basic concepts of each of these particular questions. Just give me like 2 minutes. I'll just revise the basic concept of this. Then the first question, what we had, the whole point of the matter is we need to understand that this is a patient who is not suffering from a hemopneumothorax. This is a patient who is suffering from a kind of diaphragmatic rupture. And because the intestines have already gone up, if at all we do not bring it down, there will be ischemic changes and the perforation might occur, which we don't want. And that is why we have to go in for an immediate laparotomy. That is why we have to go in for an immediate laparotomy. At this point, that is what you needed to learn from the first question. From the second question, which we discussed, we had to know that this is a patient who is suffering from a dissecting aortic aneurysm. What are the points which are pointing towards this dissecting aortic aneurysm? So as you can see here, there is a characteristic history that there is a tearing pain in the chest radiating to the interscapular region. Another important thing is on the X-ray, what you get a widened mediastinum. So these 2 points pointed towards the diagnosis of a dissecting aortic aneurysm. In the third question, what you needed to understand was that here, if at all there is a patient who is in the respiratory distress, the trachea is deviated to one side, there is an absence of breath sounds on the other side. On percussion, if you get a dull note, what you get a hemopneumothorax. You get a hemothorax. If at all you get a resonant note, the diagnosis is a pneumothorax. That is what you needed to understand in the third question. In the fourth question, what you needed to understand was what is the best treatment for the achalasia cardia? It is a surgical esophagomyotomy. First of all, it is safe. At the same time, it is having a much more efficacy. We talked about the different treatments. That's fine. So yes, definitely endoscopic treatment, that is not beneficial. It is kind of risky, but at the same time, it is not having that much efficacy also. Only 70% of the patients will respond. With respect to that, if at all you do a Keller's cardiomyotomy, close to 90% of the patients are going to respond in a much better manner. Lastly, in this particular kind of a question, you have a kind of carcinoid tumor. So in the carcinoid tumor of the appendix, how do you manage it? If at all the tumor is less than 1 centimeter, straight away go in for an appendectomy. If at all it is more than 2 centimeters, straight away go in for a right hemicolectomy. If at all the tumor is between 1 to 2 centimeters, you have to see whether it's involving the tip or the mesoappendix is not involved. Then you have to go in for an appendectomy. That is enough. If at all it is involving the base of the appendix or the mesoappendix is involved, then the diagnosis will be right hemicolectomy. Do you get this point? So yeah, that's all from my side, guys. Thank you so much. It was indeed a pleasure interacting with you. Now, I want your attention. Just give me 1 more minute, guys. So, see, understand, I'm not saying just because I'm an educator on Unacademy, I'm not saying because of this, but what I want to convey to you guys, we are coming up with many structured courses on our Unacademy Plus platform. And in that, if at all you basically join it, it will be very beneficial for you. I know that you are your best judge and you can obviously weigh things and you can consider what I'm trying to do in here. I'm just trying to convey you guys that I hope you like this particular session, and we are planning much more kind of detailed and the planned sessions on the Plus platform. So it will definitely benefit you if at all you wish to come and join it. That's all I'm trying to tell you guys. Because if see, we are coming up with the revision crash course, we are coming up with the MCQ marathon. At the same time, there are various different courses which we are also launching. These two are the highlights which will definitely boost your preparation for the upcoming NEET 2021. So if at all you're remotely interested into it, you can just click on the kind of a link below and you can basically go to my page. If at all you're on my page, please do follow me. And yeah, I mean, from there, you can basically explore all the courses which we have. If any of these particular courses interest you, and if at all you feel it might add some value for your preparation for the upcoming NEET, please do consider joining and becoming our Plus subscriber. If you do decide to do so, you can use my promo code. In this, you will get around 10% off on whatever subscription which you take. So roughly, after applying this particular discount, you will get the 6-month subscription and close to 16K, which is kind of a preferable thing for the upcoming NEET exam, guys, right? Thank you so much, guys. It was indeed a pleasure interacting with you. If at all you wish to ask me something, please do kind of ask me. And yeah, thank you so much. And yeah, do subscribe to our Unacademy channel so that you don't miss any of the videos which we are posting here on the regular basis. Okay, see you guys. So yeah, if at all you wish to come and attend it, you can definitely come and attend it tomorrow. Like tomorrow, if at all you wish to come and attend it. So here, I have episode 2. So I have started a surgery TND on the Plus platform, like on the as a special class. You can come and attend it at 11 a.m. And tomorrow again there will be a YouTube session over here at 12 p.m. So as far as the USMLE Step 2 CK is concerned, see guys, understand one thing. The content is going to be the same, but yes, I mean the kind of teaching and everything that is more directed towards the NEET PG, but at the same time, I'm sure you must be aware of this, like the concept which is basically asked in your USMLE and the concepts which are basically asked in your NEET PG, they're more or less the same. Like it is more about conquering the concept of that particular subject. As far as the surgery and medicine are concerned, I'm sure like it will be beneficial for you guys. Like for example, if at all you learn that particular subject in detail, it really doesn't matter if at all they ask you in the clinical based scenario or if at all they ask you as a one liner. It is kind of one and the same thing. So yeah, I mean you can just browse through a couple of classes and you can see if at all it will be helpful for you, right? I hope you got your answer, Rahul. I hope you got your answer. Right. Thank you so much, guys. It was indeed a pleasure talking with you. And yeah, see you guys. Bye.